Dr. Fairooz will speak on amelanotic conjunctival lesions.
I thank Dr. Hunawa for this wonderful opportunity and invitation in this instruction course of conjunctival tumor. I'll be talking on the non-melanocytic tumors of conjunctiva. Sorry, slide is not going. Okay, so these are my affiliations. Conjunctival tumors, you all know that it's broadly classified into epithelial tumors, stromal tumors, caruncular, depending upon the histological layer of origin. And this again can be defined depending upon the color. So everything in ocular oncology that we do is we look into the color and then we come into the diagnosis. So there are various colors: orangish lesion, reddish lesion, brownish lesion. So what I'm going to deal with today are those which is red, yellow, white and transparent. So the objective of this particular talk is to arrive into clinical diagnosis, differentiate these things from other benign and inflammatory condition and the diagnostic aids. So coming again to the non-melanocytic tumors, the classification, you have an array of tumors here, the benign tumors as well as the malignant tumors. So this is how a non-melanocytic tumor looks like. There is no pigmentation, there is no melanin in the tumor. And what would this be? Anyone from the audience? OSSN? All right, yeah, perfect. So I'm going to the first cases. I'll just put in some case scenarios over here. A 60-year-old gentleman, he has a slowly progressive reddish lesion in the left eye since 2 years, all right? And this is how it looks like. So the patient had undergone a biopsy before he was referred to me, an incision biopsy, and the referral doctor referred him to me as a case of OSS. And you can see this incision site over there. He was carrying a histopathology report with him, which clearly stated it's an ocular surface squamous neoplasia, moderately differentiated, from a pathology laboratory. But although it was not looking very classical of an OSSN over here. So there are certain classical features of ocular surface squamous neoplasia. You get to see some keratin, you get to see the large feeder vessels, intrinsic vessels, and well, of course, it's usually in the limbal area, in the transition zone, but this is very much away from the limbal area. Of course, you can see a dilated vessel over here, and it's more of an orangish color over here, orangish pink. So when I everted the eyelid, he had yet another lesion over there, which is more of orangish. So now, what do you think of this? Lymphoma, yes, it's a differential diagnosis, yeah. So you have a reddish nodular lesion in the bulbar conjunctiva. There is a feeder vessel. Anything else? I'll give you one clue over here. He gives a history of subconjunctival hemorrhage once, one episode. Kaposi sarcoma is very reddish. Hemangioma, not really. Does hemangioma looks like this? Like a pinkish orangish color? So from this particular history of a bleed in an orangish color, I was suspecting an amyloidosis. All right, and it came out to be amyloidosis. So there was a misdiagnosis in a benign lesion, even at the histopathology laboratory. So what we do is when a patient is referred, even as a case of OSSN or any malignant lesion, there is definitely a review of slides and blogs that is done, and it came out to be amyloidosis. So I have two pictures over here, picture A and B, above and below. I just want you to tell me which is benign, whether it's benign or malignant, both are benign or both are malignant. What about this, benign, malignant? Quick one. Benign, why? Less vascularity. This one? Malignant. Okay, all right. You're correct. So this was a lady, a 64-year-old lady who presented with this lesion. In fact, she was suspected to have a lymphoma and was advised a biopsy. All right, she was very scared of the surgery and she was like jumping from one physician to the other, that she wanted to hear that she doesn't want to undergo a surgery. So this is what it looked like. It was more cystic. All right, there was vascularity here and the history was acute. It was just a 1 month history where it was reddish in color. She also gives a history of more inflammation before, and now it has settled down. Now this is the clue. What would you think it is? Which is the muscle over here? We have the medial rectus over here. A lesion sitting over the medial rectus, acute onset, nodular cystic cysticercosis. So this was a case of a cysticercosis, a myocysticercosis. She was treated conservatively. The patient was extremely happy that the surgery was deferred. And this was how she looked like after 4 months of treatment. So this is another case, again a cystic lesion in the lower palpebral, lower pharyngeal conjunctiva over here. No vascularity, very clear, and this is a case of a conjunctival inclusion cyst. So conjunctival inclusion cyst can be spontaneous. It can be in those eyes which has undergone multiple surgeries. And this was a case where the patient has undergone a surgery in the inferior fornix for some excision of a tumor. And this is a inclusion cyst. So this lady came with a history of fullness of her eyes, like, she says it's very thick over here, my upper eyelids are thick, my lower eyelids are thick in the left eye. So I'm going to show you a clearer picture over here. This is what she had in the superior fornix as well as in the lower fornix of the right eye, all right? And this is the left eye. Easy diagnosis. Dermolipoma. So most of the time we talk about dermolipoma which is arising from the suprolateral fornix, but there are situations where the patient can have even from the inferior fornix, and we often see cases which is unilateral. This was a case of a bilateral dermolipoma arising from the superior fornix, the inferior fornix, and the inferior fornix of the other eye. All right, so she underwent excision biopsy. So what we need to be very, very careful, I'm sure Dr. Hunawar is covering over there, is a safe excision or debulking of these tumors. She underwent the same, and this is how she looks like. Very interesting case. All right, so this is a Chinese female, a 36-year-old female who comes with this lesion on the conjunctiva. It has been slowly growing. One of the doctor, the earlier doctor, has punched it. So she says it reduced a little bit in size, now it has grown to a bigger size. So what is the color of this? Looking into the color. Not red, pink, transparent. It looks mostly transparent. Like, do you think it's a cyst? It doesn't look cystic, right? Yeah, so it is transparent. It's like a chemosis there, right? Treated for chronic conjunctivitis. You can see how red her eyes are, bilaterally red. And on a closer appearance, you can see these again salmonish appearances in the right eye, lateral, medial, lateral, medial. So this is a case of a bilateral conjunctival lymphoma in a lady who was always thought to have a chronic conjunctivitis. So you should be always aware of these reddish and orangish lesion. Systemic evaluation in her was also within normal limits, and it was diagnosed as stage 1A T1N0 M0. So conjunctival tumors, conjunctival lymphoma is one of the conjunctival malignancy which is common that we come across. It is a lymphoproliferative tumor. Again, it's a spectrum. It could be reactive lymphoid hyperplasia and then turning into a lymphoma. So a biopsy is always mandated. There are prognostic factors. If it's multifocal, bilateral, fornix, and palpebral, there is a chance of systemic involvement in conjunctival lymphoma as well. The most common is the mucosa-associated lymphoid tissue, the MALT lymphoma, or the extramarginal zone lymphoma. Although the histopathology overlaps, it's very, very important to do an immunohistochemistry. Helicobacter pylori infection has been associated with this as well. So we do a clinical staging, the AJCC-TNM staging, and the Ann Arbor classification of lymphoma. I'm not going into the detail, and that's how we deal with this. This was an HIV-positive patient. I have actually done an excision of a conjunctival lesion which was suspected to be OSSN and proved to be OSSN from the nasal bulbar conjunctiva. After 8 months, he presented with this. A reddish lesion, vessels are there, it is away from the limbus. What is the differential diagnosis? An OSSN in the recurrent not recurrent, a new OSSN in the bulbar conjunctiva and the temporal side? Well, I thought so, but it did have these, papillary fronds over there, right? So the differential diagnosis was a papilloma in him, and it came out to be a papilloma in an immunocompromised patient, all right? So conjunctival papilloma does have an HPV association. It could be solitary, it could be multiple. Colors are different in a childhood as well as in adult. It is more pinkish, and fleshy fronds will be seen, all right? Now, this is a very, very classical appearance of an OSSN with keratin over that, feeder vessels, and rose Bengal staining positivity, which is arising from the limbal conjunctiva. So, ocular surface squamous neoplasia is also a spectrum comprising of dysplasia, carcinoma in situ, and squamous cell carcinoma. So the most common conjunctival malignancy, yes, is of course conjunctival SCC. It's a low-grade malignancy. It can be aggressive if it is a poorly differentiated one, and in immunosuppression and xeroderma pigmentosum patient. So this is a very classical appearance of a corneal OSSN, all right? Conjunctiva, barely anything is there. So you can see this fleshy, jelly-like jellyish appearance on the cornea. RB staining is positive. There is feeder vessel, and this is what is seen in the AIOCT, which is very, very, very classic. You can differentiate between the normal corneal epithelium and the abnormal corneal epithelium, and this is the snouty appearance, the well demarcated snouty appearance of the lesion. So it's very important to even do an AIOCT and differentiate these from other benign conditions, all right? So the patient was treated with topical chemotherapy, and then he resolved. We do see larger lesion, and these are most of the kind of diseases that we see in our part of the world because of unawareness of ocular oncology conditions. And this is a patient not immunocompromised, an old patient who's presenting with this large lesion. Taking a closer look, it in fact overrides over the cornea, and this is how. In these situations, you have to actually evaluate intraocular extension. You have to see whether there is any scleral invasion or intraocular extension in these cases with an ultrasound biomicroscopy or an AIOCT. So AIOCT, although we use it for OSSN, but there are situations if you have presence lot of keratin in the surface. In fact, there is a lot of backscattering, and you may not be able to know the exact extent, the vertical extent of these lesions. So location-wise, as I told you, OSSN is perilimbal. It can be interpalpebral, or it can involve the cornea. So these are the morphological types. You can have keratin, jellish appearance, papillary fronds, and sometimes pigmented as well. All right, so cornea, and these nodular ones are the dangerous ones. They can be intraocular extension in this, and it can be very, very aggressive. So invasive squamous cell carcinoma are spindle cell SCC, mucoepidermoid SCC, and adenosquamous carcinoma. And if it extends into the orbit, exentration is the only option. We do have AJCC classification. Clinical documentation is very, very, very important before you take the surgery, take these patients for surgery. And a diffuse variant of this kind of blepharoconjunctivitis, always be aware of the entity called the intraepithelial SGC. All right, this is sebaceous gland carcinoma, the intraepithelial or the pagetoid variant, which is presenting as a blepharoconjunctivitis involving the conjunctiva. This is a 40-year-old lady with a mass in the right eye, 6 months duration. Any diagnosis? A caruncular tumor. Sebaceous gland carcinoma, yes, that was a differential diagnosis, but this came out to be a sebaceous gland hypertrophy, hyperplasia, yeah. A 68-year-old gentleman with redness and irritation. This is classical redness and feeder vessels. This came out to be an SGC. I'm done. All right. Caruncular SGC, yes, you have to evaluate them radiologically. It's very, very important, and regional lymph nodes has to be looked for. This is a child presenting with a conjunctival lesion, but of course, it's a case of a rhabdomyosarcoma extending into the conjunctiva. What is this? Last one. Squamous cell carcinoma. Well, no keratin. There is some amount of pigments over here. Amelanotic melanoma. This was a case of an amelanotic melanoma. All right. So going on to the wide clinical spectrum of melanotic and amelanotic tumors of the conjunctiva, accurate clinical diagnosis is very, very important to differentiate between a benign inflammatory and malignant potential lesions. Thank you very much. Thank you for your patient listening.
Thank you so much.